You're welcome to Vic-Nclex Prep Consult. So, walk with me through this Nclex question. Okay, so this is Vic-Nclex question bank. So, for you to get more of these practices, you can go to wclexprep.com for you to be able to get more of this kind of a question. All right, so just walk with me. So, we have an NGN case study here, right? So we have a 44-year-old female, right? Post-acute critical care unit. So let's go. Now, Mrs. Okoro was diagnosed with Cushing disease and adrenocorticotropic secreting pituitary adenoma. She has just undergone a transphenoidal hypophysectomy. This is where we go through the nose to remove the pituitary gland. Are you following? So there is surgical removal of the pituitary gland, tumor through the nasal and sphenoid route, so through the nose. So you are the nurse receiving her and following her through the first 24 hours. So 8 o'clock, Miss Okolo arrived in the PCA, that is your unit, post care critical unit, awake and drowsy. She's somehow drowsy. This might be due to anesthesia, right? She has nasal packing in place and a small mustache, gauze dressing under her nose. She is lying flat and starts to reach up towards her nose. Are you following? So let's look at her vital sign. Yeah, her vital sign is good. We are having a stable vital sign here. So we have a blood pressure of 118/74. This is good. Heart rate is 82. Respiration is 16. Temperature is 36.8 degrees Celsius. And then pulse oximeter is, her SpO2 is 98%. This is perfect. So let's look at the question. So which nursing action is the priority at this time? Now, you need to know transphenoidal hypophysectomy. If you don't know things about this surgery, you can't be able to answer this question. Because in transphenoidal hypophysectomy, this is what is happening. What is happening in transphenoidal hypophysectomy is that we go through a surgery through the nose. So this client is going to be at risk of having increase in intracranial pressure. This is number one priority. Number two priority is that when we are doing that surgery, there are chances or likelihood that the ventricle will be damaged, and the ventricle is where your cerebrospinal fluid flows through. So these are the two problems we are going to be having in this transphenoidal hypophysectomy. So my priority is going to be on what? Instituting nursing care to prevent increase in intracranial pressure, and then watching out for bleeding. Because if there is bleeding, I have to get that blood sample. And then what am I going to do? With that blood sample, I'll get my parchment paper, place the parchment paper, put the blood on the parchment paper. By the time I put the blood on the parchment paper, if I see concentric circle, two concentric circles, whereby the innermost circle is darker and then the outermost circle is lighter. Are you following? The innermost circle is darker and then the outermost circle is lighter. This is halo test. It tells me that what? That blood does not only contains blood, it contains cerebrospinal fluid because the ventricles are damaged. For me to now confirm that this is cerebrospinal fluid, we can send it to lab. When we send it to lab and time we have ruled out diabetes, that this client is not having diabetes, and yet the sugar level in that blood is extremely high, you suspect cerebrospinal fluid damage or rupture during this surgery. So that is one of the complications. So you need to institute, your priority is going to be what? Preventing increase in intracranial pressure. Yeah. In my hospital, when patient does this surgery, we usually place them on the Satron. And that's anti-vomiting because vomiting causes intracranial pressure to rise. We place them on stool softener. We increase their fluid if it's not contraindicated. We give them food that is high in fiber because we want to prevent constipation. Constipation will lead to Valsalva maneuver, which will lead to increase in intra-abdominal pressure, worsening your intracranial pressure. If the client cannot breathe or whatever, or the oxygen saturation is decreasing, we get the client oxygen, because when your oxygen saturation is decreasing, it worsens intracranial pressure because you'll be retaining more CO2. So hypercapnia worsening intracranial pressure. What it's going to do, it dilates the veins in your brain. The veins in your brain, and you know these veins drains your head and your neck. It's going to become dilated, and when veins are dilated, there will be blood stasis that worsen intracranial pressure. So our priority action is going to be what? Selecting anything that is going to prevent intracranial pressure. So A says elevate the head of the bed to 30 degree. This is correct, but on the Nclex, I always tell my student, just don't assume option one, you read it and you feel it's correct and then you want to pick it. We just don't assume that, because you don't know what other options are saying. So make sure you walk through all the options before you finalize and choose your answer. So option B says encourage to blow her nose to clear packing. No, we don't want to do that. This will worsen it. C says have her cough and deep breathe vigorously every hour. It worsen intracranial pressure. And then placing her flat also worsen intracranial pressure. So our right answer is A. So usually place them 20 to 30 degree. Elevate the head of the bed like 20 to 30 degree. We don't go above 90. 90 worsen intracranial pressure. Don't want to try that, right? So that should be our answer. Good. That is our right answer. So by the time you go through our rationale, you're going to see it's very, very explanatory. And then you're also going to see some notes for you to study, right? You can see those things. Your nursing intervention when you're caring for someone that is having increased intracranial pressure. What are you going to do? Elevate the head of the bed, keep the head and the neck in neutral position. You see the rationale behind that. Avoid hip flexion and excessive neck flexion. Then perform a glycoma scale to assess their pupil, because increased intracranial pressure will make my pupil to become fixed and dilated. So that's what I want to assess for pupillary changes. It's one of the late signs though. You monitor for their vital sign closely. Then you maintain adequate oxygen. I told you, if the oxygen saturation fall below 95, it worsens it, because they'll be retaining more CO2 and that worsens it, right? Suction is the same thing. When you suction your client too much, you're removing all the oxygen. So that worsens intracranial pressure. So want to do cluster care and the rest of them. So let's see the next one. So by 10:30, Mrs. Okoro is more awake. You begin reinforcing discharge and recovery teaching about protecting that surgical site. That's that place where that nasal stuff is packed in her nose, so that to facilitate for healing, right? Now let's look at her vitals by 10:30. Her vitals is stable 10:30, so I don't really have any issue with her vitals here, right? So let's go straight to the question. We're having a select order apply here. So you're going to treat each option as a yes or no for it to determine whether it's the right answer, right? Now, which instruction should the nurse include? Select order apply based on the teaching to protect that surgical site, her nose, that place we have the nasal packing. What are those teaching? It says avoid blowing your nose for several weeks. Yes, this reduce intracranial pressure, so that will help that area to heal properly. Use a stool softener to avoid straining. Definitely, this is part of it. Is correct. Brush your teeth vigorously right at the gum. No, this is going to dislodge and cause problem with the suture and then delay healing. Report any persistent post-nasal drip or salty taste. Yes, this might tell us we are having damage to the ventricle, whereby your cerebrospinal fluid is coming out. And it says sneeze with your mouth open. Yes, if you must sneeze. Yes, sneezing is not really good. We want to discourage sneezing, but however, if the client wants to sneeze, we want their mouth to be open. Are you following? Right? So we want their mouth to be open, because this will help to redistribute the pressure, so the pressure will not just only be at that bridge of that nose, right? To now worsen disrupt the healing, disrupt the nasal packing and that of the suture of donor. So this will be our right answer. So our answer is going to be A, B, D, and then E. So take note. Of course, we are correct. So that is our answer. So let's continue. Okay, so let's look at the next question. All right. So we have by 2, right, 14. The pituitary controls several hormones, of course. You review which complication to watch for after entire pituitary region is manipulated, right? So let's look at her vital sign. Her vital sign by 14:00 is good as well too. But if you notice in that vital sign, you will see that her blood pressure is somehow tilting, is dropping, right? Her blood pressure is somehow dropping. Her blood pressure is somehow, but it's too stable, it's still within normal. So let's read the question. It says, for each finding, indicate whether it will be expected or a finding to report. Now we have done this surgery, so you should expect to know the kind of complication the client will have, or the signs and symptoms will notice that these are things we need to report, right? Or these are something expected after this surgery. So it's expected for us to see a mild headache. then it's usually being relieved by analgesic. But if the headache is not being relieved by analgesic, you suspect worsening intracranial pressure. So this is expected. Now, a clear drainage from the nose that stays positive for glucose. No, this tells us the ventricles is damaged, right? So we are suspecting cerebrospinal fluid leak. Then we have a small amount of old blood on the mustache dressing. This is normal. It's expected. It's old blood, right? Then a halo sign. Remember I told you about this halo sign. Is not expected. So that is it. So let's go. Of course, we got all our answer correctly, right? So let's look at the next question. The fourth screen. So let's go down. So we have by 20, that is 8 p.m. Overnight, Mrs. Okoro urine output has climbed sharply. Over the last hours, she voided 900 ml of very pale, watery urine. She's suddenly very tasty and asking for water repeatedly. Her mouth is now dry. This is a whole lot though. Let's go back. Remember we did a surgery to remove the pituitary gland, right? We did a surgery to remove the pituitary gland. So when we remove the pituitary gland, one of the complications this client can go into is they can go into Addison disease, which can lead them to go to adrenal crisis, because we will no longer be producing mineralocorticoid and the rest of them by the adrenal gland, right? And then we remove the pituitary gland. Remember, your posterior aspect of the pituitary gland will be gone. ADH will be gone. Will no longer produce and concentrate urine, right? So be urinating excessively, right? So take note of this. So when I look at this condition, I'm suspecting Addison, or what I'm suspecting diabetic insipidus. So let's have a look at her vital sign. Bam. That is it. Look at it. Her vital sign is dropping. Her blood pressure is dropping. Hypovolemic shock, tilting towards hypovolemia. She's losing a lot of fluid. That's why I'm saying that urine, 900 urine in an hour. A normal urine output should be 13 mils in an hour. She is having 900. This is bad for her. And then look at her heart rate is increasing from 78, now it's now 98. This is a compensatory mechanism because there's a sharp drop in the blood pressure, right? Now look at urine specific gravity. It's way diluted. Specific gravity is meant to be, normal specific gravity is like 1.030, right? 1.030. Now we're having 1.002. This is this is a diluted urine. And then look at our urine output per hour. 900 mils. Per hour, we're meant to have 30. Right? Now look at the serum sodium, 148. Serum sodium ranging from 135 to 145. So it's slightly high, telling us that we are having increase in serum osmolarity. That is the concentration of the blood. So hematocrit is rising. Are you following? Now say which complication are we going to suspect? So I told you there are two complications that will come to my mind. So syndrome, no, in syndrome of inappropriate antidiabetic hormone, SIADH, syndrome of inappropriate antidiabetic hormone, our urine will be concentrated because we'll be holding back water. So you're going to see the client will be swollen, but you're going to see increase in weight without edema in SIADH. So you're going to rule out that. And SIADH does not make the client to be very tasty, because here it tells us that the client is excessively tasting and then repeatedly asking for water. So when we look at diabetic insipidus, I'm going to choose this. This is part of the answer, but let's go through. DKA, no. In DKA, I would have told us the client has a history of diabetes, and in this thing, there is no lab telling us any ketone. We are not seeing any ketone here. I will not associate DKA with Transphenoidal hypophysectomy. I'm looking at diabetic insipidus and Addison. Yes, I have Addison. Yeah, so I have with here now. I'll be coming up with two answers, right? So I'm stuck with diabetic insipidus and that of Addison. Now it takes you to have content for you to be able to know which condition this client is actually developing here. Now remember, in Addison, what is their urine? They are losing fluid, so they are dehydrated. So Addison client will not be having urine of 900 ml per hour. Rather, the urine output will be less than 30 ml per hour because the client is not drinking. Are you following? The client is losing a lot of fluid because in Addison, we lose, there's lack of mineralocorticoid. Mineralocorticoid helps to reabsorb sodium, and where sodium follows is water. Are you following? So due to Addison, the client is losing sodium, right? So water is going to be lost. So, but the urine is not always diluted. It's going to be concentrated, and you're going to see those signs and symptoms of dehydration. So that alone will tell me that this is diabetic insipidus. Are you following? That alone is going to help me to tell me this is diabetic insipidus. And in Addison, in as much as possible, they'll be craving for water, but they'll be craving for salt. They are salt craver. But diabetic insipidus, they are not losing sodium. Problem is they are losing water. Their sodium in their body is so high, so they are losing water. You see them, they crave for water. And one of the tests we use to distinguish diabetic insipidus is that water deprivation test, right? So I'm going to go for diabetic insipidus. Of course, it's diabetic insipidus. It's so clear, right? So it takes you to have content, and we are going to give you that content. We also do coaching, so we'll help you with that. So it takes you to have content to be able to, because you see some people at this point, this is where they will miss it. Most Nclex students, especially those that take the test and they fail, the repeat test takers, it's not as if they don't have content. The problem is they narrow it to two answers. They will not be able to know which answer to choose. They're having problem with the first or the second one. Are you following? So we are here for you. And our question bank are like this. This is how our questions are. They are drilling. They are critical thinking. Many of my students have used it, and it has made them to pass. We have trained more than 100 plus nurses. So you can always reach out to us. You can subscribe to our question bank to see how the questions are. Is actually, we have free trial. All you just need to do is register, and then for you to be able to have the free trial, then if you're okay with it, you can go ahead and do the paid subscription. All right, so let's look at screen 5. Sorry about that. So let's look at screen 5. So in screen 5 now, we have by 2020, by 820, you gather data to describe the lab and clinical pattern of diabetic insipidus. So you know that you're actually correct, right? You can hand off accurately. So you're gathering data for you to describe that this client is having diabetic insipidus, so that you will hand off to the next nurse. So let's look at the vital sign by 820. Sorry about that. So you can see Mrs. Okoro's blood pressure keep dropping, and then her heart rate is now increasing, right? So her urine output is too high, her serum sodium level is too high, is now 150, and then her specific gravity is too low. Specific gravity measures the amount of dissolve stuffs in that urine. What are things that dissolve in your urine? Your potassium, your BN, your creatine. So it's measuring the concentration. When your urine is diluted, the concentration will be low. Specific gravity will be low. When your urine is concentrated, the urine is concentrated, right? So the specific gravity will be high. So let's look at it. Say complete the sentence about her condition. So in diabetic insipidus, the urine specific gravity is usually what? Is low. The urine is diluted, right? And the serum sodium is what? Is high, right? Because we are losing a lot of fluid, so the blood will become very concentrated. Serum osmolarity will even be greater than 300. So the nurse that is so the hormone that is deficient in diabetic insipidus is what? SIADH is what? I say SIADH is what? Diabetic insipidus is what? Antidiuretic hormone. Antidiuretic hormone is the hormone that is deficient in diabetic insipidus. So not insulin, not cortisol, right? When we're looking at deficient in cortisol, we're looking at adenosine. When we're looking at insulin, the one that is deficient is diabetic mellitus. So diabetic insipidus is an antidiuretic hormone. This hormone is primarily responsible for making your kidney to conserve water. Are you following? So this hormone is responsible for that. Under diabetic insipidus, we have two types, can be classified under two types. We have the central acting diabetic insipidus, and then we have the nephrogenic. In central, the pituitary gland is not producing enough ADH, so the kidneys cannot be able to reabsorb water from the urine. Then in nephrogenic, the problem is not from the pituitary gland. The pituitary gland is actually producing, but the receptors in the kidney are not sensing that ADH, so we are going to lose a lot of water. So in central acting diabetic insipidus, we give them desmopressin, vasopressin. They respond to it in central. But in nephrogenic, because the problem is not from the pituitary gland, if you give them vasopressin, desmopressin, they will not respond. So what we use is diuretics such as your thiazide. Thiazide helps. Don't ask me why, but just take note. Thiazide is one of the things that we use in nephrogenic diabetic insipidus to increase those receptors to be sensitive to what? Antidiuretic hormone. So let's go. Definitely we got our answer. Our answer are Correct. So let's look at the last side. So we are coming to the end of this question, right? So it states the provider is notified and confirms diabetic insipidus, right? It simply means you have been answering correctly. If you're answering the Nclex question, you know you're not going to see whether you got it or not. It's because I put it in tutor mode, right? Now, you anticipate and carry out priority nursing action, right? So let's see if we always check vital sign. It's very, very important. Be checking any stuff. So we have. So you can notice now her vitals is now improving. Her BP is now improving, right? But her blood pressure is still going down. Say is improving. Sorry, her blood pressure is still going down. Her heart rate is rising, right? Then her urine output is too high. Serum sodium is too high. Specific gravity is just too low. It's still very, very low. All right. So let's say it says which action are appropriate. Appropriate priority, select all that apply. So which actions are appropriate for this client that is having diabetic insipidus? Look at what it said. The provider is notified and confirmed diabetic insipidus. You anticipate and carry out priority nursing action. So which action do you think the healthcare provider can institute for this client that is having diabetic insipidus? That's what it's asking. So let's walk through. A says strict monitor intake and output and daily weight. Yes, weight is going to help us to know their fluid volume status, how they are retaining fluid or how they are losing fluid. Then we have to institute strict intake and output, right? Then B says restrict all oral fluid to less than 500. No, diabetic insipidus will give them fluid. It's SI88 that will restrict fluid to at least 500 to 1000. And if you want to use fluid to correct that sodium level that is diluted in SI88, we use hypertonic saline, such as your 3% sodium chloride, right? And when you're using that 3% sodium chloride, you have to use infusion pump. You have to give it slowly in SI88, because if you don't give it slowly, it will lead to pontine myelinosis. It will dry up the brain. So just take note of that. And you see the client will start manifesting with those neurological deficit issues, seizure, delirium, changing level of consciousness, and the rest of that. So let's continue. So we don't restrict fluid here. Rather, we encourage them to have more fluid because they are dehydrated. So that is the thing. So C says anticipate administering desmopressin. Yes, we use desmopressin to correct this institute. Now take note on the Nclex. If Nclex does not tell you whether it is nephrogenic or central, just assume it's central, except if they specifically tell you it's nephrogenic. So here it is central, right? So we assume it's central. So we have to give desmopressin. The central diabetic insipidus respond to desmopressin. Desmopressin is a synthetic ADH, or we use vasopressin, which is a synthetic ADH. So take note of that. It will make them to retain water. So one of the side effects that it can lead to fluid volume overload. All right. Then this says monitor serum sodium and neurological status. Yes, because sodium level is going to be high. So we'll keep monitoring it, right? Then it says encourage or replace fluids to match output and prevent dehydration. Of course, we want to do this. So these are answers. So our answer is going to be A, C, D, and then E. So let's see. Of course. So we got it. So that is it. We got it. So thank you very much. And then we submit. Let's see our score. 100 over 100. So that is it. So that is it there. So thank you very much for working with me through this NGN case study. So remember, to get more questions, you can just visit let's see, Vic-Nclex So let's walk through. So it's Vic-Nclex prep.com. So you visit it. So this is how to get the question bank. You just exercise patience. So this is it. So if you want any of our coaching services, you can just actually scroll down or just click on contacts, and then you see a contact form. You just fill in your email. It's very, very important. Fill in your full name, your email address. Then this phone number is your WhatsApp, because we reach out to you through WhatsApp. Right, that's easier. Then let us know the coaching service you want, what you want. Is it coaching? Is it CGF? We also do one-on-one tutoring if you want that, and then you can type it here for us what you want and just send it to us. A representative of us is going to reach out to you. You follow it, so take note of that. A representative is going to reach out to you, or if you want to get more faster response, you can just use this WhatsApp number here. This 081 061 90751. This one, send me. This is my direct line. just send me an email and then I will get in touch with you immediately. So take note of that. So these are our testimony. You can read them. These are people that have used us and they have passed. Are you following? So to get started, to subscribe for the question bank, all you just need to do is do what you can click on get started, or you click on start free practice here. You following? Once you do that, sorry about this because I've already logged in here. This is my own. So once you click on that, it takes you where you're going to register. You just register. Once you register, you have free access to question bank. You have I think around 28 or 20, I think up to 50, I think 50 practices that are free for you to see how our question is. So you can see our question bank. Yes, so we have at least, you can see it here, we have 584 ngn. Very, very good. Ngn case study, 584 ngn types of questions. Then classical, we have 2,226. So that is it. So that is it. So do remember to visit us and subscribe us. So we are your best plug in Nclex and coaching. We coach very well, believe me. We take time to explain that. We believe that if we can work on the foundation for you, you won't have problem on the Nclex. Why people fail is due to the foundation. The foundation is weak. So what we do is we focus on the foundation, focus on the foundation, and then we build it. We have so many nurses all over the world. I have students from India. I've had two Indian students. I have Uganda. Yes, most of my students, you see them Uganda students. I'm expecting, I want to even have from Zambia or even Sri Lanka as well too. I want to have from Zambia, Sri Lanka. I've had Kenya. I've had about 8 Kenya students that have passed through me. Then many of them UK. My UK nurses are so many, and then those ones in the US, there are so many, they're uncountable. In short, those are the ones that used to give me disturb me every time. Boss Vic, right? So that is it. So we have many Nigeria. So we are Nigerian based currently right now. So we are Nigerian based in class academy. Because we are in Nigeria, that does not mean we don't know what we are doing, right? I have written my class exam. So since I passed for the past 3 years, I have been coaching, helping nurses to achieve this exam seamlessly without having any issue. So most of my students, most of them that come are always repeat test taker, right? That is the thing, because what we do is we build our foundation. That is what we do. So we have our life courses. If you know that you're the one that is to work and you have problem, that you cannot be able to meet up with the life class, don't need to bother yourself. We have our life courses whereby you just review whenever you're available. Is recorded as well. All right, so thank you and do have a wonderful day. Bye.